Then when will you? Very good evening to all of you. On behalf of Indian Society of Anesthesiologists, Kerala State Chapter, I warmly welcome all of you to another exciting episode of AnaesthesiaCONNECT, our weekly academic program that brings together anesthesiologists and PG students from across the country for learning and discussion. Today's session features a long case discussion on chronic kidney disease, an important and frequently encountered challenge in anesthesia practice. And also, it's an important question for PG students in their examinations. So, we are privileged to have Dr. Gurudat CL from Mysore as our external examiner for today's discussion. The case will be presented by postgraduate students from Government Medical College, Kottayam, Dr. Emil Ansu Philip and Dr. Anaka M. I'm sure it will be an engaging and academically enriching session for all of us. Unfortunately, due to some personal reason for some unseen reasons, Dr. Lata Janardhan, professor and head of the Department of Government Medical College, Kottayam Anesthesia Department, Madam is not able to join us today. Nevertheless, we extend our sincere thanks to the department and the presenters for their efforts in preparing this case discussion. I would also like to remind all our members about our upcoming national conference, which will be held at the beautiful venue of Kovalam, Thiruvananthapuram, on next November end. So, we are hosting a national conference after long 27 years. So we encourage everyone to register early and actively participate in this prestigious conference. Also, please remember to follow ISA Kerala Instagram page to stay updated with academic activities, announcements, and highlights from our programs. And as always, do not forget to participate in ISA Kerala Kahoot quiz, which has become an exciting and interactive part of AnaesthesiaCONNECT. Finally, as we approach tomorrow, I would like to extend advance wishes for International Women's Day to all wonderful women in our profession who contribute immensely to patient care, academics, and leadership in anesthesiology. So thank you all for joining us today. Let's begin today's session. Over to Dr. Gurudat, sir. Sir, please.
Good evening. I hope I'm audible.
You're audible, sir.
Okay. Thank you so much, Dr. Binil, for the nice introduction. And now we are going to have a case discussion on chronic kidney disease patient posted for non-renal surgery. So we have two students from Kottayam Medical College, Department of Anesthesia, Dr. Emil and Dr. Anaga. I want Dr. Emil and Anaga to introduce themselves and start presenting the case.
Good evening all. I am Dr. Anaka, junior resident from Government Medical College, Kottayam.
Good evening all. I am Dr. Emil Ansu Philip, junior resident from Government Medical College, Kottayam. Today,
no,
we are
actually
going to
present the case.
Okay, sir.
Today, we are going to present a case of chronic kidney disease for right inguinal hernia, totally extraperitoneal mesh repair. Case details. A 58-year-old male who is a farmer by occupation, hailing from Kottayam, Kerala, presented with complaints of swelling in the right groin since 1 year, associated with intermittent pain at same site since 6 months. The patient was apparently normal 1 year back when he noticed swelling in the groin. The swelling was insidious in onset, gradually progressed from small size to current size of 5 × 6 cm, which was prominent on standing, walking, and coughing, and disappears on lying down. The pain was mild intermittent with a dragging type of pain, which was insidious in onset and non-progressive, which gets increased on coughing and straining. There is no history of chronic cough, chronic constipation, or bladder disturbances. No history of fever, severe pain with redness at site of swelling and sudden increase in size. No history of swelling on opposite side. Patient is a known case of chronic kidney disease since 3 years, which was diagnosed in evaluation for frothy urine, facial puffiness, and swelling of hands and feet. He was initially on medical management, but for past 1 year, he was started on hemodialysis. Initially, 5 cycles of hemodialysis was done through right IJV. During that time, patient was hospitalized for 1 week. No history of further hospital admission. Currently, dialysis is being carried out 2 times per week through an arteriovenous cannula in the left forearm, which was created under local anesthesia, and the procedure was uneventful. Last dialysis was done day prior to the surgery. There was no history of decreased blood pressure, breathing difficulty, allergic manifestation, and muscle cramps during dialysis. There was no history of hematuria or melena, no history of chest pain, dyspnea, palpitations, or syncope, no history of fever, recurrent respiratory tract infections, no history of generalized pruritus or EC bruisability, no history of muscle cramps, numbness, or tingling sensation, no history of seizure, memory loss, or altered sensorium. Past illness. Patient is a known case of hypertension since 10 years on regular medication, chronic kidney disease since 3 years on dialysis. No history of other known comorbidities, no history of previous major surgeries, or no drug allergies. Patient is able to climb 2 flights of stairs and could do household chores. Drug history. Patient is on TAP telmisartan 40 mg OD, TAP clonidine 100 microgram BD, TAP sodium bicarbonate 500 mg OD, TAP calcitriol 0.25 microgram OD, injection erythropoietin 4000 units twice weekly subcutaneously. Family history. There is no significant family history. Personal history. Patient follows a mixed diet and normal appetite. The sleep is normal. Bowel habits regular. Urine output is decreased.
On general physical examination, the patient is conscious, oriented time, place, and person, and is cooperative. He is moderately built and nourished. Mild pallor is present. Bilateral pedal edema present. No uterus, cyanosis, clubbing, or lymphadenopathy. The patient is 168 centimeter tall and the weight is 60 kg with a BMI of 21.2 kg per meter square. An AV fistula is present in left forearm. Vital signs. The pulse is 78 beats per minute. Regular rhythm, normal in volume and character. Condition of vessel wall is normal. All peripheral pulses felt. No radioradial or radiofemoral delay. Thrill is present over the AV fistula in left forearm. The blood pressure is 140 over 90 millimeters of mercury in supine position and 132 over 82 millimeter mercury in standing position. The respiratory rate is 16 per minute, regular and abdominothoracic. SpO2 is 99% in room air and the temperature is equilibrium. Airway examination and spine. The facies is normal, external air is normal, mouth opening is 5 cm, modified malleability score is class 1, thyromental distance is 6.5 cm, temporomandibular joint is mobile and 1 finger insinuation possible, no loose tooth or artificial dentures, neck movements are normal and painless, the spine is normal. Systemic examination. First is gastrointestinal system. On inspection, the abdomen is not distended, no visible peristalsis, no scars or sinuses of distended veins. Umbilicus is midline, groin swelling visible while standing and coughing. On palpation, soft, non-tender, and the abdomen is soft, non-tender, no guarding or rigidity. There is no organomegaly. On percussion, no abnormal dullness, no fluid thrill. On auscultation, normal bowel sounds. Hernia local examination was not done. Cardiovascular system, JVP not elevated, no visible scars or sinus or visible pulsations. Apical impulse felt in fifth intercostal space, half-inch lateral to midclavicular line. S1 and S2 normal, no murmurs. Respiratory system, trachea is midline, chest wall appears to be normal. Normal vesicular breath sounds heard in all lung fields. No added sounds. Chest wall expansion is equal on both sides. Central nervous system, higher mental functions normal. Sensory and motor functions normal. Cranial nerves normal. Summary. A 58-year-old farmer from Kottayam, now taking hypertension for past 10 years, chronic kidney disease for past 3 years, now on hemodialysis for past 1 year, while left forearm AV fistula, presented with swelling in right groin associated with intermittent dragging pain. On examination, the patient is conscious oriented with stable vital signs. Mild pallor, bilateral pedal edema present. Abdominal examination revealed swelling in right inguinal region and is diagnosed to have right inguinal hernia and is planned for totally extraperitoneal mesh repair. Diagnosis: chronic kidney disease stage 4 on hemodialysis, posted for TEP mesh repair for right inguinal hernia.
Okay, thank you. You have presented the case very well. Actually, most of the things what the question should be asked in in the history you have done, and a detailed examination also you have done. And before actually going in for the discussion of the case, I would like to ask you a few questions regarding your history and examination. So then we will go into discussion the anesthetic management of this particular patient. Now, one thing in the history, as you said that this patient was on hemodialysis. He's on hemodialysis for the past 1 year, but initially he had hemodialysis through his right internal jugular vein. Almost about, I think, 5 times he has had hemodialysis through his right internal jugular vein. So why that history is important to you as anesthesiologist?
Prior cannulation of IJV may have distorted the anatomy of the neck, and the further cannulation during the surgery might be needed, and it will be difficult if you are using landmark technique to cannulate the IJV.
So it's always better to go straight away for an ultrasound guided
IJV
cannulation, if at all, if it is required, because many times if you think that that particular surgery requires a lot of fluid shifts, so you may require a central venous cannulation. And also if this patient comes for transplant surgery, renal transplant surgery, likely he may require a renal transplant surgery. Then also you require to cannulate the internal jugular vein, and then it should be that this particular history becomes very pertinent. So that is very good. You have taken that. Second thing is, you said that his METs are he's able to climb 2 flights of stairs. So what does mean to you as an anesthesiologist?
For these patients, the MET score is more than 4. So there is a lower chance for major adverse cardiac events for this patient. So
that is very important, isn't it? Because majority of these patients with the chronic kidney disease will also have cardiovascular disease. So taking this particular history of physical capacity becomes very important, so that you know any advanced cardiac tests, non-invasive or invasive tests to be done or not. So that is another very important history you have taken. So one more thing is that in your history, you should go into details about the coronary artery disease, because these patients invariably will have coronary artery disease, isn't it? So why they do have coronary artery disease, these CKD patients?
The CKD patients are 10 times more risk for ischemic heart disease due to accelerated atherosclerosis, which is due to the impaired triglyceride clearance and impaired lipoprotein lipase activity, which lead to decreased lipolysis. It will increase the risk of atherosclerosis. And also there is endothelial dysfunction due to RAS activity. It will produce reactive oxygen radicals. It will lead to endothelial dysfunction.
Patients also will have hypertension. So that produces change in the left ventricle. So that also will make them more prone for coronary artery disease. So you should go into more details about coronary artery disease, especially whether they have angina. Very important. And if they have angina, you will have to, differentiate whether they have a stable angina or an unstable angina. Why it is very important to know whether they have a stable angina or an unstable angina? Why this is very important for you? Because, suppose you have gone for a pre-anesthetic evaluation and you have found that the patient has an unstable angina, typical unstable angina history. So what does it mean to you as an anesthesiologist, and why it's so important? Can I suppose the patient gives his history of unstable angina? Can I take him up for elective hernia repair tomorrow?
We'll have to do further investigations and do a proper echo and other stress testing if needed, and find out the cardiac status of the patient before taking for surgery.
Now, what is unstable angina? It is an active cardiac condition, always threatening the life of the patient. Unstable angina is an active cardiac condition. Any patient having an active cardiac condition, you should not take up for any kind of elective surgery unless it is a life-threatening or limb-threatening surgery. So, because unstable angina is an active cardiac condition, and you have to differentiate whenever the patient gives you history of unstable angina, you have to differentiate whether it is just unstable angina or that's like acute coronary syndrome, whether by doing a cardio-specific troponins, you have to differentiate whether patient also has got a acute myocardial infarction. So that is the reason, history of unstable angina becomes very, very important. So that is another thing which you should go into details. And also, suppose if the patient has coronary artery disease, he'll be on multiple other drugs also. Like most common drugs, the patients can be on antiplatelet drugs, he can be on statins, or he might have had a revascularization procedure, either a coronary stenting or a CABG, isn't it? Open surgery. So this history becomes very important. You all know that I don't want to go into details about this ischemic heart disease and anesthesia, because last episode of AnaesthesiaCONNECT was on ischemic heart disease and anesthesia. So all those things regarding patient having a stent, what to do, whether to continue dual antiplatelet therapy, everything has been discussed. So, but when you are taking, because you know that the patient with chronic kidney disease also may have coronary artery disease, and he may have all these problems because of the coronary artery disease. So you have to go into details about this particular history. So another thing, what you said is patient also has pedal edema. So why should you look for pedal edema in a patient with chronic kidney disease?
To look for the signs of fluid or not. The patient might be hypervolemic. The CKD patients have a tendency to be hypervolemic. So we should check for bilateral pedal edema or facial puffiness or other signs of fluid or lot, like rise tight JVP or bilateral crepitations to assess the fluid status of patient.
Very nice answer you have given. Suppose, let us say that patient has all these, because you have found out that he has got pedal edema. He should not have had a pedal edema, but he has got the pedal edema. So if he has pedal edema, plus, as you said, that bilateral crepitations are there. So what you should do now, what is the complication he can develop if you take him up for surgery?
He can develop pulmonary edema.
Yes, definitely, isn't it? So because you think that he already has hypervolemia, because hypervolemia is a common complication of chronic kidney disease. So naturally, intraoperatively, he may develop a pulmonary edema even when you give any fluids or even any position change, like if you put him into a head-down position. So suddenly he may develop a pulmonary edema. So that is the reason why it is very important to know about this, whether he has pedal edema, puffiness of face. And also one more thing you have not examined is the spine examination. So whether the patient is posted for GA or not, so it is always better to examine the spine. So when you are making this thing airway as a routine checkup, pre-anesthetic evaluation, so make it a point to check for the spine also. Suppose, let us say that he is not posted for TEP, he is posted for regular open inguinal hernia repair. So then you would have gone for probably, we'll discuss about it, probably you would have gone for a regional anesthesia like spinal or epidural or whatever it may be. So that is the reason it is always better to check for the spine, because a patient with pedal edema may also have edema in the back, because dependent edema. Suppose if he is lying down for a long time, so dependent edema. So that is another very important thing you should check that you have not done. Another thing in the examination is pulse. So what kind of a pulse you expect in a patient with chronic kidney disease?
If the patient is hypervolemic, we will expect a high volume pulse.
No, he need not be hypervolemic, but another problem is always there in these patients.
Anemia. It can
Anemia.
produce
So chronic anemia is very,
binding.
very common in these patients. And what is one of the compensatory mechanisms whenever a patient has chronic anemia?
The patient, there will be this shift of oxygen dissociation curve to the right due to increase in 2,3 people.
And I'm asking you about, no, that is what, in the exam, you should be, careful and listen to the examiner's, question. I was talking to you about pulse and then anemia and then compensatory mechanisms for anemia. So what you should have replied regarding the cardiac output.
Increased cardiac output.
Cardiac output is going to increase. How cardiac output is going to increase in patients with anemia? What are the two things that are there in the cardiac output?
So,
One, heart rate, and another is the stroke volume.
Yes, sir.
Both stroke volume and heart rate will increase in these patients.
Yes.
So how pulse will be there? So because you have to use your common sense when you are presenting.
Yes.
So will there be tachycardia in this patient?
Yes, sir. Tachycardia.
Yeah. If he has anemia, invariably they'll have anemia. That's what you have said. Pallor was there in your examination. Invariably they can have tachycardia and high volume pulse. So that is one more thing you should always look for during your examination. So you assume that the patient has tachycardia and high volume pulse, and if he doesn't have, if he has got bradycardia, then you'll have to think about other causes of bradycardia in these patients, like even patient may be on beta blockers or patient may have hypothyroidism. So there are other things, which becomes very important for us as anesthesiologists, you will have to look for. Okay, so that is what is important thing there. Another thing about the apical impulse, you have said that apical impulse is in the 5th intercostal space and half an inch lateral to the mid-clavicular line. So what kind of an apical impulse you expect in these patients with chronic kidney disease with hypertension? Because this patient has got history of hypertension for the past 10 years.
Sir. Yes, sir. And the patient might have left ventricular hypertrophy, which shifts the apical impulse outwards and downwards.
Yeah, outwards and downwards. Now, can it be in 5th intercostal space? Normal apical impulse will be in the 5th intercostal space.
In 5th intercostal space.
And half an inch medial to mid-clavicular line. Now you have written as shifting outwards, you have written, but downwards. It will be in 6th intercostal space and definitely, half an inch lateral to mid-clavicular line. So that also you should always, think about these things, because invariably this patient will have a left ventricular hypertrophy. Another thing is what kind of an apical impulse will be there in patients with LVH? It will be an heaving apical impulse.
Okay, sir.
Isn't it? Heaving apical impulse. So you have to, bring out all these things in your clinical examination when you are writing down or presenting the examiner regarding the findings. And another thing is you should also check for autonomic neuropathy. Are these patients prone for autonomic neuropathy? You have examined, CNS, and you have written about the somatic neuropathy is not there. Like you have written that sensory and motor systems are normal. So you also look for autonomic neuropathy in these patients. Is knowing about autonomic neuropathy important in these patients with CKD?
yes.
Yes, sir.
Why?
Because in autonomic neuropathy may lead to delayed gastric emptying, postural hypotension is a thing, and myocardial ischemia can present, silent myocardial ischemia.
Very good. And they will also have exercise intolerance. Sudden cardiac death is very common, isn't it? And they may not tolerate any change in position, severe hypotension, resistant bradycardia. So there are a lot of implications of autonomic neuropathy and anesthesia. So, you know about the test Clark and Ewing's test for autonomic neuropathy, for cardiac autonomic neuropathy. I think. So just, many times why I am asking you these questions is many times when we are discussing, the discussion can go to other systems also. So that is the reason why you should know. So you know that heart rate response to deep breathing, heart rate response to standing, heart rate response to Valsalva. These are parasympathetic tests, and heart rate response to, blood pressure response to standing, and blood pressure response to hand grip, sustained hand grip. So these are sympathetic. So just remember about these things when you may be asked about this, because these patients are highly prone for autonomic neuropathy, and we know that diabetes also can be there in these patients as a cause for chronic kidney disease, and invariably chronic diabetes can produce autonomic neuropathy. So that is another important thing. Okay, now let us start discussing about the anesthetic management of this patient. These questions I just wanted to ask you regarding your history and examination, what things you should remember and correct yourself when you are presenting during your examination. Okay, now briefly, because you said that the patient has a chronic kidney disease, can you just tell what do you mean by chronic kidney? How do you define chronic kidney disease?
Chronic kidney disease is defined as progressive and irreversible loss of kidney function for 3 or more months, which leads to a decreased GFR less than 60 ml per minute per 1.73 meters square.
So very good. So that mainly GFR less than 60 ml for more than 3 months. So it is a chronic irreversible, derangement of the kidney functions. Very good. So the other important thing is, what are the causes that can produce chronic kidney disease?
The most common causes for chronic kidney disease are diabetes followed by hypertension. Other causes include glomerulopathies like primary glomerulonephritis or infected glomerulonephritis, SLE, sarcoidosis, tubulointerstitial disease like Alport syndrome, also analgesic glomerulopathies, and hereditary syndromes like medullary polycystic kidney disease.
Okay.
And also
most common causes, if you think, you will always be correct, like for example diabetes, hypertension, and then glomerulonephritis, polycystic kidney disease, and collagen disorders. So these are the most common. So why? And you all know that diabetes mellitus is nearly 40% of the patients with chronic kidney disease may have diabetes, and 27% of hypertensive heart disease also can have chronic kidney disease. So these two are the most common causes of chronic kidney disease, and hypertension can be a cause or an effect of chronic kidney disease, isn't it? Yes. So because diabetes is so common, and you have to, suppose if the patient also gives history of diabetes, then you will have to think about all the other systems that are involved with diabetes, and especially the complications of diabetes. Can you mention delayed complications of diabetes, which are very, very important?
It may be macroangiopathies or microangiopathies. The macroangiopathies include cardiovascular disease, coronary artery disease, and peripheral vascular disease. And microangiopathies include diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy.
Very good. And acute complications?
The acute complications may include diabetic ketoacidosis or hypertonic hyperosmolar.
Hyperglycemic hyperosmolar state. That is more common in type 2 diabetics, isn't it? Plus, these patients, if they are on treatment, they are highly prone for hypoglycemic attacks. So it's very important to know about this, because in the exam you may get a patient with diabetes with chronic kidney disease. Okay, so then all these things will be very important, and also what drugs the patient is on for diabetes, and how to manage the glycemic status intraoperatively. All these things will become very important and pertinent once you get the patient with diabetes having a chronic kidney disease. So, okay. Now, this patient, you have already said that this patient has got an inguinal hernia, and a few questions also you asked to rule out whether the patient has any obstructed hernia or strangulated hernia. Again, that becomes very, very important, because if the patient has got an obstructed hernia or a strangulated hernia, so he may require an emergency surgery.
Yes, sir.
And emergency surgery in a patient with CKD, you have a lot of problems. We can discuss that also if time permits. Okay. So now, what investigations you would like to do in these patients?
We'll do a complete hemogram, which includes hemoglobin level, total count and differential count, and platelet count is also noted, and coagulation profile including PT, INR, and
Wait.
APT.
So, because whenever you tell a particular investigation, it has to be an indicated investigation.
Yes, sir.
Isn't it? We should not do an investigation which is not indicated. So here definitely hemoglobin is very much indicated, because already we said that these patients likely to have anemia. So what are the causes? Why do they develop anemia?
In this patient, there is a decreased erythropoietin level, which causes a decreased RBC production. Next, there will be dietary deficiency of iron and folic acid, which in turn leads to anemia. And
So what happens to the RBC lifespan?
Lifespan is also decreased in uremia, and also hemolysis is also add up to hemolysis. And
what about the any bleeding dialysis these patients can have?
yes, sir. There will be platelet function impairment in this patient, and because there is a decrease in factor von Willebrand factor, there is a impairment in adhesiveness and aggregation of platelets. So even though if the platelet counts are normal, there will be impaired platelet function in these patients.
So they may be having microscopic hematuria, microscopic bleeding through their gastrointestinal tract, isn't it? This is because the dysfunction of the platelet functioning. So another very important thing is, what about any problem with their bone marrow, which
Yes,
can
sir.
lead to anemia?
Yes, sir. These patients might have secondary hyperparathyroidism, which may lead to bone marrow fibrosis, and thus decreasing the production of RBCs.
So and also this patient is on dialysis. Can dialysis produce any problem for his RBCs?
Dialysis may cause hemolysis in patients.
No injury to the RBCs, so that itself can produce hemolysis, and that also can be a cause for anemia. So there are multiple reasons why these patients can have anemia. So if the patient is having anemia, should you correct it before taking up for surgery?
No.
This patient is already on a drug for
Yes, sir.
anemia. I think Emil can talk.
We will target hemoglobin for this patient, CKD patient, is 11 to 12 gram per deciliter. If it is less than 5, only we will start.
Just before you answer, one thing I wanted to tell you, because probably about say 10-15 years back, we used to accept these patients with severe anemia, like even 6 grams or 7 grams of hemoglobin. We used to accept them. Why we were accepting them with that kind of hemoglobin also? In those days, well, when erythropoietin was not available for us. Because chronic anemia compensation. Now you can tell me what compensatory effects would have taken place in a patient with chronic anemia.
It can shift the ODC curve to the right due to increased 2,3
DPG.
2,3 DPG, and also acidosis can shift the curve. There will be increased cardiac output and decreased microcirculation.
Okay, so there will be definitely, and viscosity of the blood is also decreased. Hagen-Poiseuille law, so that there will be better movement of blood, because the decreased flow will be better to the tissues. Okay, anemia. So you have to correct anemia by erythropoietin. Already the patient is on erythropoietin 4,000 international units twice a week. So what is the dose? Sometimes you may be asked about the dose of
50 to 150 units per kg subcutaneously per week.
2-3 divided doses also you can give. Any other drug one can give a better, than erythropoietin, having a longer half-life and more potency?
Darbepoetin alpha.
Darbepoetin alpha can be given 0.45 milligram per kg body weight per week, isn't it? Or 0.75 milligram per kg per once in 2 weeks. So darbepoetin alpha can also be given. Okay. Now you also said total count, differential count. Why do you want to do a total count and differential count?
This patient is highly prone for infection due to decreased cellular and humoral responses. That's why we should do total count and differential count to rule out any infections.
Okay. One more thing you said is platelet count. So any importance regarding the platelet count in these patients?
Usually the standard coagulation profile and platelet count are usually normal, but qualitative function of the platelet is impaired here.
Okay. Now one question I want to ask you. This patient is on repeated hemodialysis. Do they use heparin during hemodialysis?
Usually, if the patient is posted for surgery, we'll
I am
avoid
not
heparin.
asking about posted for surgery. He has been having repeated hemodialysis for the past 1 year, isn't it?
Yes, sir.
So
Yes.
he would have been exposed to heparin, isn't
Yes,
it?
sir.
Can heparin
Yes, sir.
produce any problem for platelet number?
Heparin-induced thrombocytopenia will be there.
Isn't it? That is called as HIT or heparin-induced thrombocytopenia. That is the reason why it is always better to get a total number of platelets. We know that platelet dysfunction is there. So for that, you have to do platelet function test you have to do to know the functioning of the platelets, isn't it? So platelet number also is important because this patient is on repeated hemodialysis and exposed to heparin. Okay, what other investigations you would like to do?
The other investigation should include a renal function test, which should include urea, creatinine level, and urine test like albumin, total urine albumin creatinine ratio, and 24-hour urine protein, and
Why
urine
do you want urine albumin creatinine ratio?
For the staging of CKD, we use the criteria is albumin to creatinine ratio. So we should assess the albumin to creatinine ratio. If
So there are
it is
two types
divided
of
into
staging, isn't it? Two types of staging is there. So one is G staging and another is A staging.
staging.
What is this G staging? So you just tell about the stages of chronic kidney disease.
Chronic kidney disease is staged according to GFR and albumin creatinine ratio, and also according to albuminuria. According to GFR rate, it is divided into G1 to G5. G1 is GFR more than or equal to 90 ml per minute per 1.73 meter square, which is normal or slightly increased GFR. G2 is GFR up to 60 to 89 ml per minute per 1.73 meter square, which is mildly decreased GFR. G3 is divided to G3A and G3B. G3A is 45 to 59 ml per minute per 1.73 meter square, which is mildly to moderately decreased GFR. G3B is 30 to 44 ml per minute per 1.73 meter square, which is moderate to severely increased GFR. And G4 is 15 to 29 ml per minute per 1.73 meter square, which is severely decreased GFR. And G5 is end-stage renal disease, which is GFR less than 15 ml per minute per 1.73 meter square. According to the albumin creatinine ratio, it is divided into A1, A2, and A3. A1 is less than 30 milligram per gram. And A2 is 30 to 300 milligram per gram, whereas A3 is more than 300 milligram per gram.
As anesthesiologist, why do you know about the staging?
We should know the staging to assess the severity of the disease and also to for the risk stratification.
Risk stratification. Yes. Okay, that's very nice. When do you call a patient to have an end-stage renal disease?
When the GFR is less than 15 ml per minute per 1.73 meter square, we should call.
Yeah. And why do you want to know if the GFR is between 15 to 30?
We can.
Stage 4. Is it important? For the sake of the patient. What is the preemptive renal transplantation?
The early renal transplantation will improve the survival rate better than renal replacement therapy for 5-year survival rate following the renal transplantation, it is about 70%, and the patient undergoing dialysis without renal transplantation is only 30%.
Isn't it? So that is another very important thing to know. You can always discuss, because it is always multi-speciality involvement will always be there, along with the nephrologist, cardiologist, the anesthesiologist, the surgeon. So everybody has to, multidisciplinary discussions have to be done. So that is one thing you should always remember about the staging and the importance as far as the anesthesiologist is concerned. Okay, now creatinine you said also you want to do. Can we know about from creatinine, can you know what is the GFR?
Yes, sir. We can know by Cockcroft-Gault formula, which is 140 minus age into lean body mass divided by 72 into creatinine. If the patient is a female, we'll multiply it by 0.85.
Okay. Why age is also considered there?
Because there is a decline in GFR by a percentage of 10% after the age of 40 for every decade.
But GFR declines. What about creatinine? It will remain normal, or it also will increase?
It will remain normal. It will remain normal because the creatinine is also dependent upon the muscle mass of the patient, which might also decline with age.
Okay. So, now renal function tests you have done, and fractional excretion of sodium and urinary osmolarity. All these are important if the patient has developed an acute renal failure.
Yes.
On chronic kidney disease. So just to rule out whether it is a pre-renal, renal, or post-renal, you require all these: the urine osmolarity, urine specific gravity, and then urinary sodium excretion and fractional excretion of sodium. So we'll not go into details about that because of the lack of time. So anyway, but remember that suddenly, your discussion may go in for acute renal failure and how to diagnose and what are the different causes. Okay. So now what other tests you want to do? As far as cardiovascular system, what tests you want to do?
For cardiovascular system, we will first assess the exercise tolerance of the patient. Next, we will do ECG to rule out whether there are any arrhythmias is there, LVH, left ventricular hypertrophy is there, or conduction blocks and prior ischemic heart disease changes in the ECG. Then we can also do echo to rule out any regional wall motion abnormalities, to know about the ejection fraction of the patient, to know the LVH, then diastolic dysfunction, and also about pericardial effusion.
Any pulmonary arterial also you can know?
Yes.
Pulmonary arterial pressure. Is it important in these patients with chronic kidney disease?
Yes, sir. Pulmonary there is a 40% chance of pulmonary arterial hypertension in patients with end-stage renal disease.
So if they have pulmonary hypertension, then prognosis will not be very good if they are posted for any surgery. So for risk assessment, it is important to know that the pulmonary arterial pressures as well. Now, you said that all these changes may be due to hypertension they have, isn't it? Maybe as a cause or an effect. So what may be the cause for hypertension in these patients?
Hypertension may be due to the sodium water retention. This patient sodium water retention, and also due to increased renin-angiotensin activity.
Now, can you just tell about this renin-angiotensin aldosterone path?
Due to reduced renal perfusion and decreased sodium filtrate in the load, it can activate the juxtaglomerular apparatus. It will secrete the renin. Renin will activate the angiotensinogen, which is present in the liver, to angiotensin 1. The angiotensin 1 will convert to angiotensin 2 by angiotensin converting enzyme, which is primarily present in the lungs. This angiotensin 2 will activate the adrenal gland and releases aldosterone, and it will also direct action like angiotensin 2 has. It promote arteriolar vasoconstriction will be there, sodium, chloride, and water reabsorption, as well as potassium excretion will be there, and it will also increase the sympathetic activity, and thereby it increases the blood pressure.
Okay, very nice. That because of increased renin activity, and also because of the hypervolemia and sodium retention, these patients can develop hypertension, and it can be a chronic hypertension, and sometimes it can be a resistant hypertension, and these patients may be on multiple antihypertensive therapy, isn't it? So that also you should always remember about. Okay, now coming to these patients can have multiple electrolyte imbalances, and so you
Yes,
have
sir.
to get these electrolyte studies also. So
Yes,
what multiple electrolyte imbalance these patients can have?
These patients might have hyponatremia, hyperkalemia, hypocalcemia, hypermagnesemia, or hyperphosphatemia.
So they can have hyponatremia majority of the times, isn't it?
Yes.
What may be the cause for hyponatremia, though they have retention of sodium?
The patient might have dilutional hypernatremia, as there is a
Dilutional hyponatremia, isn't it? That is one thing. So then the second important thing, and which is very, very important for us, is hyperkalemia. So that is what is very, very important. What may be the cause for hyperkalemia in these patients?
In the CKD patients, the potassium secretion is affected in the distal nephron, so it will precipitate the hyperkalemia. And also the drugs like aldosterone, potassium-sparing diuretics, beta blockers, this will also increases the hyperkalemia. And the CKD is a state of metabolic acidosis. In acute acidosis, if there is a decrease of pH by 0.1 unit, it will increase the serum potassium by 0.5 milliequivalent per liter. All these are causes
Why
of
in metabolic acidosis hyperkalemia occurs? Reason for hyperkalemia and metabolic acidosis?
There will be a shift of exchange of intracellular potassium with the H+ to maintain the electrical neutrality.
Very good. So potassium will shift from intracellular compartment to extracellular compartment.
Yes, sir.
That is the reason. Alkalosis, the opposite occurs, isn't it? Alkalosis, hypokalemia, and acidosis, hyperkalemia. So these patients can have hyperkalemia. It's very important. And also, suppose if the patient has acute hyperkalemia, you should know how to treat it out. Can you just tell the steps of managing hyperkalemia? Just steps. Enumerate, because we don't have enough time.
We have to give induction calcium gluconate, 10% 10 ml IV over.
No, don't tell. One is giving calcium. Does it decrease the potassium levels?
No, it stabilizes the cardiac cell membrane.
Yes, it antagonizes the effect of potassium on the heart. Okay, one. Second.
Nebulized beta-2 agonist salbutamol.
Okay.
Then insulin dextrose can be given IV.
Okay.
Diuretic.
We can also give diuretics like furosemide.
Potent loop diuretic. Okay, then
cation exchange, cation binding resins can.
Okay.
Then also in refractory hyperkalemia, we can do hemodialysis.
Yeah, last as peritoneal dialysis or hemodialysis, isn't it? So that is what you have to, and this is very important question that will be asked for you in the exam also, because potassium levels are very important. Suppose let us say that potassium level is about 5.5 to 6. Why it's important to you?
If there is an increase in potassium, there is a high chance of developing arrhythmia in this patient, and it might lead to a sudden cardiac arrest.
No, that is there. In order to use a particular drug,
succinylcholine.
Yeah,
we cannot use succinylcholine.
So, what is the maximum potassium levels you can still use succinylcholine?
Less than 5 milligram per deciliter.
5.5. 5.5 milliequivalents per liter of potassium. You can still, up to that level, you can use. Anything above 5.5, you cannot use, because succinylcholine itself is going to increase the therapeutic dose, increase by 0.5 to 1 milliequivalent. And as long as potassium levels are less than 5.5, there won't be much problem as far as dysrhythmias or cardiac arrest is concerned. So once they go beyond 6, all the the ECG signs, and then even the patient may go in for dysrhythmias, that too malignant dysrhythmias and arrest can occur. So that becomes very, very important regarding the potassium levels. So what about calcium in these patients?
Calcium, these patients are also hypocalcemia due to decreased intestinal absorption of calcium, as well as there is a fall in vitamin D3, which will also decrease the calcium levels.
Plus, what happens to the phosphate levels?
Hyperphosphatemia will be there.
And can it produce hypocalcemia?
Yes.
How?
Hyperphosphatemia causes soft tissues to accumulate the calcium phosphate, thereby it will causes
It produces secondary hyperparathyroidism, isn't it? Hyperphosphatemia will produce secondary
hyperparathyroidism,
which will lead to actually resorption of calcium from bones to maintain calcium levels. Plus, vitamin D3 levels will be decreased, or which will not be, which gets affected from the production of from the kidneys because of the hyperphosphatemia. So once vitamin D3 levels are less, so calcium absorption from the GI tract also will come down. So that also can produce hypocalcemia, and resorption of calcium from the bones will produce a syndrome. What kind of a syndrome is it? Syndrome or an effect, you can always say. Renal osteodystrophy, isn't it? Yeah. Why should you know that this patient may have renal osteodystrophy?
Because if you are opting for a general anesthesia, positioning may be required, and if the bones are weak due to this osteoporosis, there is a chance for vertebral fractures, which we should
especially positioning for epidural or spinal can produce vertebral fracture. Even your epidural needle, the Tohi needle, can go through and through the body of the spine. So because the bones would have become so soft because of the renal osteodystrophy. So this is another thing. And again, they are highly prone for fractures. And the patient may come to you with a fracture for reduction of the fracture, open reduction, and you may have to give anesthesia. So that's why these things become important. And another thing you said, metabolic acidosis, these patients. So how do you know whether the patient has metabolic acidosis or not?
By assessing the ABG.
One is ABG directly. Any other signs will be there when you are examining these patients, because you know that this patient may have metabolic acidosis. How it's compensated usually? How it gets compensated?
Hyperventilation by.
So that is why respiratory rate becomes important.
Yes, sir.
During your examination, if the patient has more severe metabolic acidosis, so he'll be hyperventilating. His respiratory rate would be very high, isn't it? So that's how you can, even before doing an ABG, you can think, yes, this patient may have metabolic acidosis, because the compensation is by respiratory alkalosis, isn't it? So okay, now why should you know whether the patient has got metabolic acidosis?
Because if there is a decrease in pH, the drugs, the PK of the drugs may affected, and there will be a delayed action in drugs like local anesthetics in this patient. For example, the PK of lidocaine is 7.8 and that of bupivacaine is 8.1. So if the pH is increased, it might affect the onset of action of these drugs.
No, other very important thing about this is, as you said, the effect of metabolic acidosis on the heart. There is always metabolic acidosis directly can produce cardiac depression, myocardial depression.
Yes, sir. Yes, sir.
And the second thing is your inotropes and vasopressors may not be very effective in these patients with metabolic acidosis. And third thing is these patients are highly prone, because of the metabolic acidosis, for malignant dysrhythmias.
Yes, sir.
And fourth thing is, if you are using, you said about local anesthetic. What about benzyl isoquinoline group of muscle relaxants like atracurium and cisatracurium? Will their metabolism also get affected if the patient has metabolic acidosis?
No, sir. Atracurium and cisatracurium is eliminated by Hoffman elimination.
Okay.
No, what is Hoffman's elimination? No, you said, what is Hoffman's?
This is spontaneous, non-enzymatic and non-organ dependent degradation of certain quaternary ammonium neuromuscular blockers at physiological pH and temperature.
Hoffman's elimination is pH and temperature dependent degradation of atracurium and cisatracurium. What is the pH of atracurium and cisatracurium? What is the pH of the drug? The pH of atracurium and cisatracurium is 3.5. 3 to 3.5. it is always, very low pH. So that's why once it is added to the blood with a pH of 7.4, it starts degrading. Now, if the pH of the blood is decreased because of metabolic acidosis, what happens to the degradation of atracurium and cisatracurium? Gets delayed.
It becomes lower.
Isn't it? So there can be prolonged effect of atracurium and cisatracurium if the patient also has metabolic acidosis. So this also you should always remember. Since you mentioned about drugs, not only local anesthetics, again, half-month elimination, because it depends on pH. So pH is on the lower side with metabolic acidosis, that can get affected. Okay. Now, do you want to have an X-ray chest?
Yes, sir. We'll take an X-ray chest.
Why do you want to have
the patient might have pulmonary edema, cardiomegaly, or pericardial effusion, and pleural effusion might be there.
No, one thing I just want to ask you. By your examination, can you find out whether the patient has, pulmonary edema, or pleural effusion, or cardiomegaly?
Yes, we can.
You can check, isn't it?
Yes,
so
sir.
if you have not found any signs of, pleural effusion or pulmonary edema, patient is comfortably sitting, why should you unnecessarily expose the patient to an X-ray test? That is why I told you only indicated tests. Unnecessarily don't do. Exposure to X-ray definitely, is not good, isn't it? So that is why you need not have to do. And invasive, non-invasive cardiac tests definitely you can do, like perfusion, myocardial perfusion tests also can be done if they are indicated. If the patient's meds are less than 4, or you cannot make out what is the number of meds, and if the patient is posted for a high-risk surgery, then they are required. Okay, you have done all these tests. Now, how do you prepare this patient for TEP surgery?
As patient is hypertensive, I will optimize the BP of the patient. I will correct the anemia and coagulopathy if present. Correct as well electrolyte balance as well as fluid balance. And perioperative hemodialysis.
You want to optimize the blood pressure of these patients, isn't it? Now the patient is already on 2 drugs.
Yes, sir.
He is on clonidine and he is on ARBs. Telmisartan. So what is the importance of these drugs for you as an anesthesiologist? Should you continue them or on the day of surgery?
As this
Because
is
that in a part of your preparation of the patient, isn't it? Whether to stop this drug or whether to continue the drugs. How
for
about
this patient, for this patient posted for a TEP, a laparoscopic TEP repair, we are not expecting a huge fluid shift or blood loss, so we can continue telmisartan for this patient.
Very good. So suppose if the patient was posted for, say, a major surgery where you expected a lot of fluid shifts,
yes,
then SE inhibitors and ARBs to be stopped on the day of surgery. Some books also say that 48 hours before only you should stop them. And suppose if the patient is on is a known diabetic and he is on metformin and SGLT2 inhibitors. So SGLT2 inhibitors have to be stopped at least 3 days before.
3 days.
Metformin have to be stopped on the day of surgery because of lactic acidosis is a rare complication, but these patients with metabolic acidosis and over and above having a lactic acidosis can be a problem. Okay, now clonidine, should you continue on the day of surgery or should stop?
Yes, sir. We'll continue clonidine on day of surgery to decrease the stress during induction for this patient.
And multiple advantages are there with clonidine, so you continue. But any problems with clonidine and anesthesia?
Yes, sir. There will be an exaggerated chance of exaggerated hypotension for this patient when it is combined with our anesthetic agents.
Plus, he is on. You said that you are going to continue with telmisartan also and clonidine also. Plus, these patients with CKD may also have autonomic neuropathy. Plus, if you are using propofol, which is again a drug which produces peripheral vasodilatation and myocardial depression, so synergistically the patients can go in for severe hypotension, isn't it? So these things you have to remember about. And The other important thing is, other than optimization of hypertension, what are the other methods of preparation of these patients?
We should do correct the anemia or coagulopathy processing, correct
Very
the acid-base.
How do you correct coagulopathy? Because that is because of the platelet disorder.
Yes. We can
Any
give
drug can be any particular
we
drug?
can cryoprecipitate or desmopressor.
Desmopressin, 0.3 micrograms per kg body weight given over 15 minutes can also be. So optimization of coagulopathy becomes a part of preparation. Yes, anything else? Now optimization of hypertension, optimization of anemia you said, and optimization of coagulopathy you said. Anything else other than these things regarding preparation?
Optimization of acid-base imbalance as well as electrolyte imbalance, and we can protection of the AD.
Now, how do you optimize the electrolytes and acid-base status?
We can do preoperative hemodialysis. Can be done.
Okay, hemodialysis. And if the patient has got severe acidosis, you can also use sodium bicarbonate if the pH is less than 7.1 without hyperkalemia and without increased amount of fluid status. Then you can definitely use sodium bicarb to correct metabolic acidosis, optimization, that also. And anything else in the preparation as far as, because you said that gastrointestinal problems of these patients can also be like a delayed gastric emptying.
Yes, sir.
So you want to prepare this patient for prevention of aspiration?
Yes, sir. Aspiration prophylaxis can be begun with the metoclopramide or H2 receptor blockers.
Okay. So you have to take precautions for acid aspiration syndrome, prevention of aspiration. Okay. So these are the important things about the preparation of the patient. Okay, now you have taken care of all these things. Plus, you have to be very careful with the AV fistula, the patient having AV fistula. So that also you have to see that, as a part of preparation, you have to protect it while transferring the patient to the OT also. Okay, now what are your goals of anesthesia?
Anesthetic goals including maintaining the renal perfusion by maintaining the hemodynamic stability as well as intravascular volume status as well as renal blood flow, and prevent further harm to the already compensated kidney by avoiding hypoxia, hypertension, hypothermia, hypovolemia, and hypercarbia, and avoid nephrotoxic blood salts.
Very good. And also maintain strict asepsis.
Yes.
Because these patients have immunosuppression and they are highly prone for infections. So throughout the procedures, you have to maintain strict asepsis, and also maintain deep plane of anesthesia, and also you have to be very careful with positioning of the patient also, because already we discussed about the patient having osteodystrophy, renal osteodystrophy. Okay, now everything is you have had your goals also mentioned. And beautifully you have mentioned every goal that is required to be considered. Now, what is the technique of anesthesia you have planned for this patient with TEP?
General endotracheal anesthesia. I will proceed with the general endotracheal anesthesia.
Very good. So why not go for a supraglottic airway device? And
as these patients might have a chance of gastroparesis and aspiration risk is there, the supraglottic airway disease is contraindicated in this patient, and we will go for a care intubation.
Yeah, very good. So otherwise, if any other surgery is there where you could have used a supraglottic airway device in a patient with chronic kidney disease, do they have any benefit compared to the endotracheal tube? A patient who is absolutely kept nil oral status, where you expect aspiration chances to be very less. Other surgeries?
Decreased tracheal irritation.
The most important thing, that the maintenance of depth of anesthesia may not be as much that is required for an endotracheal tube. One.
Yes.
And introducing a supraglottic airway device will produce less sympathetic activity, isn't it? So that is another advantage with a supraglottic airway device. So if another surgery where you don't expect aspiration, not laparoscopic surgery, where the intra-abdominal pressure is raised, and that can also produce problems if you have got a supraglottic airway device. Okay, you have selected general endotracheal anesthesia. So now how do you proceed? Should you give any anxiolytic on the previous night of the patient? Any pre-medicants?
I will give pre-medication to the patient, including anxiolytics like alprazolam, 0.25 mg can be given. And you can also give aspiration prophylaxis with metoclopramide and estroreceptor blockers. Then on the day of surgery, prior to induction, we can give.
No, you have to start a IV line also, isn't it?
Yes, sir.
So, any particular precaution you will be taking for starting an IV line?
We will avoid the left forearm if there is a AV fistula present there, and we will prefer an IV line in the left hand on the dorsum of the hand. Is most
left
preferred.
hand or right hand?
A right hand dorsum.
Isn't it? Left side he has AV fistula.
And
should not start any IV line on that particular, because it can produce, can affect the AV fistula. Even it can produce thrombosis of the AV fistula, which you want to avoid, because this patient requires the AV fistula for later dialysis as well, isn't it? So that is another very important thing. One more thing you did not mention during preparation is regarding the dialysis. When you should ask for a dialysis for this patient before taking a first.
Ideally, dialysis should be done 24 hours preceding to the surgery and should be completed 6 hours prior to the surgery to maintain
any particular reason? Any particular reason within 24 hours and before 6 hours? No, after 6 hours.
Before 24 hours, before 6 hours, there is a chance for hypovolemia, and after 24 hours, there is a chance for developing of hypovolemia and fluid overload in this patient.
Okay. One more problem within 6 hours, if you after dialysis, the patient.
If there is heparin used in dialysis, then we will have to wait for 2 times the half-life of heparin to so that it is eliminated from the system.
It is better you wait for at least 3 to 4 half times of heparin. What is the half-life of heparin? How much?
3 hours.
90 minutes.
90 minutes.
Yeah, it is roughly 60 to 90 minutes. IV, isn't it? Because dialysis means they would have used intravenously the heparin, usually about 90 minutes. So at least 3 or 4 half-lives, you have to wait. Okay, so that is another reason why. And another very important thing is you should know about the dry weight of the patient. Dry weight is the weight of the patient when he is euvolemic, when he does not have hypervolemia or hypovolemia, that you can get from nephrologist. Any 2 kg variation is fine. More than 2 kg, if the patient has increased his body weight, that shows that the patient has hypervolemia. If the body weight is decreased more than 2 kgs than the dry weight, the patient may have hypovolemia. So this becomes very important for you, because you don't want any patient to have hypervolemia or hypovolemia when he is posted for surgery, because both are very dangerous situations that can produce. Hypervolemia, already we discussed, can produce pulmonary edema. Hypovolemia can produce severe resistant hypotension.
Yes.
Isn't it? So that can produce, one of our goals is to avoid hypotension in these patients. That can produce an acute renal failure in a patient with a chronic kidney disease, isn't it? So that is why avoiding hypotension becomes very, very important. Okay, now starting an IV line in this thing, do you take any precautions? This chronic hypertensive patient, the pain can produce more shooting up of blood pressure.
We will give a local. We can explain the procedure to the patient and give a local anesthetic at the site before placing the cannula.
Or can you use Emla cream?
Yes.
You can use Emla cream also. You need not have to keep it only for pediatric use. You can also use Emla cream even in adults, especially in these patients where you think that even that amount of that prick can produce pain and then hypertensive response. So that is another very important. So you have to start in some fluid also. What fluid you would like to start?
Balanced salt solution can be used.
Again, there is a controversy, isn't it? Because balanced salt solution contains potassium. Should you use potassium containing fluid or a normal saline?
Normal.
Because in this particular surgery of TEP, do you expect to give a lot of fluids or only just for maintenance?
Just for maintenance.
Isn't it?
Yeah.
So should you give potassium containing balanced salt solution or a normal saline?
Normal
Because
saline.
I know that because you know that normal saline can produce hyperchloremic metabolic acidosis. And any hyperchloremic metabolic acidosis can produce afferent renal, renal vascular constriction or afferent arteriolar constriction, and also directly can damage even the renal tubules. These problems are there with hyperchloremic metabolic acidosis. But that is when you give at least more than 3 liters of normal saline. So this also you may be asked in the exam. So many of the books say that, of course, in these kind of surgeries, you can even avoid balanced salt solution, especially potassium containing. Because in ringer lactate, how much of potassium is it? 5 milliequivalents per liter, isn't it? So you can even go for normal saline. That is absolutely fine. Even if you go for balanced salt solution, especially if you go for plasma light and all, absolutely no problem. Because anyway, we are not going to infuse him too much to produce hyperkalemia also. Okay, so you have started IV line. So you have taken the patient inside the OT. What monitors you will be connecting to the patient?
The pre-induction monitors that we are going to use are ECG, SpO2 probe, NIBP, and the NIBP should be kept on the arm where there is no AV fistula, that is the right arm, and and we should also monitor the urine output of this patient. 5D DCG is used, and we can also
urine output you want to monitor. Why
Yes,
do you want to
sir.
monitor the urine output?
If
In a patient with end-stage renal disease, he may not have much urine output, but still it may be required to calculate the amount of fluids to be given
yes, sir.
intraoperatively, isn't it? So you have to give insensible losses plus whatever the urine output is there. That amount has to be given for the next hour, isn't it? So for knowing, that's okay. ECG, which particular lead you want to connect?
Is lead 2 and V5 is connected
Very good. So why lead 2?
to look for any arrhythmia.
What most common arrhythmia that can occur in these patients?
Atrial fibrillation.
Atrial fibrillation. They may already have an atrial fibrillation. Almost 40 to 50% of CKD patients can have atrial fibrillation. The most common this thing. So you have to, suppose you expect the patient to have dysrhythmias. What else you keep ready in the OT?
Defibrillator.
Yeah, you have to keep antiarrhythmic drugs.
Yes, sir. Yes,
And also a defibrillator. Don't jump to defibrillator always. So it is always antiarrhythmic drugs, because how do you manage atrial fibrillation? 2 methods of managing atrial fibrillation.
Pharmacological management will
No, it is rate control and rhythm.
rate control and rhythm control. For rate
Isn't it?
control,
So
we'll
that's
go
what
for-
that's what I told you, that in the exam your answer should be clear to the point. You
Yes,
just
sir.
say rate control and rhythm control. Let the examiner next ask you, how do you control the rate? How do you control rhythm? So you are generating more questions, and
Yes.
number of answers will be more. You will get more marks. Just stop
Yes.
there. Rate control, rhythm control. Anyway, we'll not go into details about managing atrial fibrillation. So V5 for myocardial ischemia, isn't it? So lead 2 for arrhythmia. So, and what about pulse oximeter?
Yes, sir.
Any particular mode in the pulse oximeter also, or any particular parameter in the pulse oximeter you want to know in these patients for management of fluids, intraoperative fluids?
Perfusion index and pulse pressure variation.
Pleth variability index, PVI, isn't it? So that is very important. So any change of more than 13% pleth variability index, patient is fluid responsive, because that is one of the dynamic parameters, because many times the fluid management may require dynamic parameters. Like, if you have got an invasive blood pressure monitor, or you have got a transesophageal echo, so you can go for stroke volume variation, you can go for pulse pressure variation, you can go for systolic pressure variation. Now, if you do not want to have an invasive monitor, isn't it, in this patient for posted for TEP, so he may not require an arterial line or a central venous cannulation. So a pulse oximeter with pleth variability index, if it is there, so that can indicate whether the patient requires extra fluid or not. Or a non-invasive cardiac output monitor, if you have, that also can be used. So these are the monitors. End-tidal carbon dioxide EtCO2 monitor also you can connect once you hold the mask. So till then it may not be required. And neuromuscular junction monitor, is it important in this patient?
Neuromuscular monitoring can be done using the nerve stimulator as
Is it an important monitor intraoperatively?
No, sir.
For TEP patient, we are not considering neuromuscular monitoring.
No, okay. One thing I want to ask you is, intraoperatively, which neuromuscular blocker you would be using in this patient?
We are preferring atracurium or cisatracurium for this patient.
Okay. So you already know that atracurium and cisatracurium may have a prolonged duration of action.
Yes, sir.
Isn't it? And the patient can develop a residual neuromuscular palsy even if you, give neostigmine and glycoparylate, even if you reverse him properly also. And the problems of residual neuromuscular palsy, especially in these patients.
Okay.
If you had used steroidal, neuromuscular blocking agents like vecuronium or rocuronium, you would have even given Sugammadex, isn't it? So, but here you want to go for atracurium or cisatracurium. So that is the reason it is always. And one more thing, you don't want the patient to move during the procedure, isn't it? You want to have a still patient during laparoscopic procedures. So that also you can make out only if you are continuously monitoring the neuromuscular junction with a monitor. So that's how it may be. Are you practicing neuromuscular monitoring?
No, sir.
Have you any time used?
No.
You're not using?
Not using.
Okay. So it becomes important in this patient with
neurosurgery patient.
No, any patient now, many countries, they have made it mandatory when you use a neuromuscular blocking agent, you should monitor the neuromuscular junction.
Okay.
And especially these patients who are prone for residual neuromuscular blockade. And chronic kidney disease patients are notorious to develop residual neuromuscular blockade. So it may be an important monitor. Okay. So monitoring is okay over. So how do you induce this patient? What pre-induction drugs you will give, and how do you induce?
Pre-induction drugs include anti-anxiolytic injection midazolam 0.01 mg per kg IV will be given. Then we can give injection dexamethasone 4 to 8 mg IV as an antiemetic. Then we can give, for reducing the stress response, we can give injection fentanyl 2 microgram per kg IV. Then we can give injection lignocaine at a dose of 1 to 1.5 mg per kg IV for reducing the stress response as pre-induction drugs.
All these drugs, whatever you said just now, can they have any pharmacokinetic and pharmacodynamic problems in a patient with CKD?
In patients with CKD, there is a chance for prolongation of action of these drugs as the elimination is affected.
Not only elimination, what happens to their albumin level?
Albumin, as the albumin level decreases, there is a increase in free fraction of the drugs, thus leading to a prolonged duration of action.
Not only prolonged. See, free fraction is that means the unnecessary, the drug may produce many of the side effects of the drug. It is as if you are giving a higher dose, isn't it? So you have to be very careful with what doses you are going to give. That is why just 0.1 milligram per kg body weight of midazolam is fine, because again midazolam is protein bound, albumin bound, and lidocaine. How lidocaine is bound to albumin or something else? Lidocaine.
Lidocaine is bound to alpha-1 acid glycoprotein.
Isn't it? So, what happens to alpha-1 acid glycoprotein in these patients? In CKD patients.
CKD patients.
There can be an increase in the alpha-1 acid glycoprotein. But the problem in these patients with lidocaine is they are highly prone for seizure, that is, the CNS activity of lidocaine. So seizure potential is very high with lidocaine. So you have to be careful how much lidocaine you are going to give. Just 1.5 milligram per kg body weight IV slow is also fine. Okay, now with these drugs, what drug you will be using for induction? Is it thiopentone? Is it propofol? Which one?
We prefer propofol for this patient.
Any problem with propofol?
There may be exaggerated hypotension, so it should be given in a titrated dose based on the blood pressure of the patient.
Otherwise, can you go for a sleep dose of propofol? What is sleep dose of propofol? No, you calculate the dose that is required for this patient.
Yes, sir.
You know that it is 2 milligram per kg body weight. Give half the dose slowly. Continue with the patient, conversation with the patient, and then wait for about 20 seconds. That is 1 arm brain circulation time. And then keep giving 10 milligrams and wait for 15 to 20 seconds. Keep repeating increments of 10 milligrams. Once the patient stops responding and there is loss of eyelash reflex, you can stop. Though, what kind of induction you would be going in these patients?
We could go for a rapid sequence induction in this patient.
Though you are going in rapid sequence induction, you have to be extremely careful with propofol, how you give. Because there can be a very severe hypotension because the patient is on ARBs, patient is on clonidine, and the patient may also have autonomic neuropathy. All these things, and patient is a known hypertensive patient with vasoconstricted peripheries, and sudden vasodilatation can produce severe hypotension and it can be refractory. So you have to be extremely careful. It's always better to go for sleep dose. So would you like to go for succinylcholine or something else?
If the potassium of the patient is less than 5, then we can go for succinylcholine. Otherwise, for trachyuria may be preferred.
Okay. Suppose let us say that there is contraindication for succinylcholine.
We can go for rapid sequence induction with the rocuronium.
Rocuronium. What is the dose of rocuronium you would be using?
Rocuronium, the Walsh dose is 0.3 mg per kg.
For rapid sequence
1 mg per
0.3
kg.
milligram per kg body weight is only ED95 of rocuronium. And for
1
regular
mg.
intubation, you give 0.6 milligram per kg. For rapid sequence induction,
0.9 mg per kg.
1.2 milligram per kg body weight.
Okay.
Isn't it? And whenever you want to give rocuronium for rapid sequence induction, what other drug you should always keep ready? Suppose you are not able to intubate. It's an unanticipated difficult airway. Sugamadex, isn't it? So if you want to reverse the patient with Sugamadex, after 1.2 milligram per kg body weight of rocuronium, what is the dose of Sugamadex?
16 mg per kg.
16 milligram per kg. And any problem of Sugamadex rocuronium complex in a patient with chronic kidney disease?
Renal excretion may be there, so worsening of renal function.
No. It has to be excreted, this complex to be excreted through only kidneys. So it remains in the plasma for a long time. It will not get excreted. This combination of rocuronium with sugammadex. And many studies have not found any problem, even though it remains in the body for a long time. So you can still use rocuronium and can use reverse it with sugammadex if required. And even at the end, you can reverse the patient with sugammadex. There is absolutely no problem. Okay, so now you have intubated the patient. Okay, and somebody has asked, can we use etomidate? What about your answer? Can we use etomidate in this patient? When do you use etomidate? In which kind of patients?
The cardiac, if there is a cardiac issue, then we can.
Suppose, this patient can have cardiomyopathy and diastolic dysfunction, systolic dysfunction, and his ejection fraction may be on the lower side, maybe 25, 30, low ejection fraction, and the METs of less than 4. In all these patients, definitely you can go for etomidate. Otherwise, if the patient does not have all these problems as far as cardiovascular system is concerned, propofol is better. Why propofol is better over etomidate? Because somebody asked about etomidate.
Etomidate can cause
propofol.
What benefit of propofol over etomidate? Which can suppress the intubation response better?
Propofol can suppress the intubation stress,
isn't it?
better
So
than
propofol can suppress the intubation response better. It also has got an antiarrhythmic effect, and also it suppresses the airway reflexes. It also has got suppression of the postoperative nausea and vomiting.
Okay.
All these things are not there with etomidate, isn't it? And another problem with etomidate is suppresses the steroid response from the adrenal cortex. So in a patient who has immunosuppression, so you have to be careful, isn't it? So, but if the patient has cardiomyopathy or patient has cardiac failure compensated, then better to go for etomidate than propofol. So that is why everything is individualized or personalized for that particular patient. It is not general. Okay, I'll use propofol, I'll use etomidate. It's not like that. That is the reason you have to do a proper pre-anesthetic evaluation and consider a particular type of whether the technique of anesthesia or even the drugs that you use. Okay. Now, how do you maintain this patient? You have intubated the patient. So I don't want to ask you about rapid sequence induction, how you are going to do. Anyway, you have done the rapid sequence induction. There was no problem. You could intubate also. Now, how do you maintain this patient? A patient with CKD for TEP.
Maintenance of anesthesia with we can keep in the inhalation agents as isoflurane is a better choice as it undergoes 0.2% metabolism only and it will produce less fluoride levels compared to sevoflurane. So it is a better inhalation agent of choice. Then we can.
How much of it is metabolized? Sevoflurane.
20.
Which is 20% metabolized. You see, in the exam, you get caught like this only. Which inhalation anesthetic agent is 20% metabolized? I'll tell you, it is easy to remember. Halothane 20%. Sevoflurane 2%. Then isoflurane 0.2%. Desflurane 0.02%. Just remember, halothane 20%, sevoflurane 2%, isoflurane 0.2%, desflurane 0.02%. All two. Easy to remember for the exam purpose, isn't it? So you can also use desflurane, isn't it? Not only isoflurane. And sevoflurane, another problem of sevoflurane is compound A. Though it's a theoretical problem, so if you can avoid, you can definitely avoid, isn't it? In order to prevent compound A formation, it is, many advisory is there that you cannot go for very low flow anesthesia. You have to use at least 1 liter of fresh gas flows with sevoflurane. So whereas with desflurane or with isoflurane, you can go for even metabolic flow or minimal flow, low flow anesthesia. So that you should remember. Okay, that is about this thing. And any problem with these inhalation anesthetic agents in these patients with CKD? As
It
far as the
decreases-
hemodynamics is concerned?
It causes myocardial it has a inhalation myocardial depressant action as well as to produce vasodilatation. Thereby, it will produce hypertension, exaggerated hypertension.
Yeah, that is always there because he is a hypertensive patient. So that you should always keep in mind. And what is the position that is adopted for TEP?
Trendelenburg. We'll have to go for a Trendelenburg position for this patient.
Okay. Any problem of position and CKD patient?
Increased it will increase the venous return and that will produce increased cardiac output.
So in a patient with CKD, where you expect patient to prone for pulmonary edema, where he has got decreased albumin levels, that produces a decrease in oncotic pressure, and the pulmonary capillary leak is very, very common in these patients, isn't it? And patient may also have hyperolemia. So this Trendelenburg position can produce problems, pulmonary edema. So that you have to keep in mind. And any change in position should be very gradual. Should be very gradual to prevent all these problems. And what about the pressures?
Peak airway pressure might get increased when patient is positioned in
No,
Trendelenburg.
they are going to use carbon dioxide, isn't it? Carbon dioxide
Yes,
is going to be. And though it's an extraperitoneal, it can also apply pressure over the abdominal viscera. So that also can decrease the renal blood flow. And that is the reason you have to be careful with the maximum pressure of less than 12 millimeters of mercury. So that is another thing which you should always remember. And carbon dioxide can accumulate and respiratory acidosis can occur, isn't it? So that you have to maintain by increasing the rate. Suppose you are going to increase the PEEP. Any problem in these patients? Increasing PEEP.
It will produce a decreased. It will cause decreased venous return. Thereby, it will decreases the cardiac output. It will activate the renin, and sympathetic stimulation will be there, and it will activate renin natriuretic peptide. Thereby, it increases the.
One thing is, you don't want to decrease cardiac output in a patient who is anemic also. That is one of the compensatory mechanisms, isn't it? He is anemic. So you have to be extremely careful because cardiac output is the one which is making the compensatory effect. So that is the reason why you should maintain the cardiac output. Another thing is, can you hyperventilate? Or you want to avoid hyperventilation intraoperatively?
Yes, if we hyperventilate the patient, it will cause air trapping and it will increase the intrathoracic pressures. Thereby, it will decrease the preload and decreases the cardiac output.
No, you should think hyperventilation means carbon dioxide. What happens to carbon dioxide level if you hyperventilate?
It will decreases. It
will
decreases.
decrease. Produces respiratory alkalosis. If there is respiratory alkalosis, iatrogenically you are producing, what happens to the OD curve?
It will shift to left, and there will be a decreased affinity of.
Now you are reducing the cardiac output. You are also shifting the OD curve to the left, and those two are the absolute compensatory mechanisms that have taken place by the body. You are going against that, so you have to be extremely careful. And what type of ventilation you have to do? Now with all, even intraoperatively, we are going to have a particular type of ventilation.
Controlled ventilation.
Lung protective ventilatory strategies. So that you have to adopt, lung protective ventilatory strategies. What about intraoperative fluids? Already we discussed.
Yes, sir.
Because there is hardly any fluid loss. So you replace insensible losses plus the urine output. How much is the normal insensible losses?
For a minor surgery, it is 2 ml per kg, and for a major, it is 4 ml per kg.
No, that is nothing to do with minor surgery or major surgery, isn't it? It is usually Insensible losses I am talking about. I am not including the blood loss. Insensible losses you calculate as 1 ml per kg per hour.
Okay.
So in this patient, because it's a laparoscopic procedure, not much of, hardly any blood loss, 1 ml per kg per hour plus the urine output, that amount you have to give for the next hour. So you can either give balanced salt solution or normal saline, it is fine. Now, intraoperative analgesia, which drug would be ideal? Any newer drug which has been introduced in India? Because fentanyl also can have a prolonged duration of action in these patients with CKD. And post-operative respiratory. Any short-acting opioid you can use?
Remifentanil.
Yeah, remifentanil may be an ideal choice, isn't it? So, okay. So the surgery is over, fortunately for you. And another thing is managing intraoperative hypotension. You may be asked, managing intraoperative hypertension. So those things you should always. Hypotension, you have to be extremely careful. So you may have to reduce the depth of anesthesia. You may have to increase the fluids if required. If you are monitoring the blood variability index or cardiac output, if you think that the patient is fluid responsive, you can give fluids, or which vasopressor you can use.
Vasopressin.
Which vasopressor? Is it ephedrine, or is it phenylephrine, or is it noradrenaline?
We could use phenylephrine for this patient.
So better to go for ephedrine. Because phenylephrine is a pure alpha agonist that can produce vasoconstriction of the renal vessels. If at all, if it is required, better to avoid vasopressors. Okay, surgery is over. How do you reverse when this patient?
I reverse the patient with a neostigmine and glycopyrrolate. But neostigmine is cleared by the CKD. It has prolonged activity. It will prolong the parasympathetic activity. So there can be a chance of precuriorization also in this patient.
No, neostigmine has got a prolonged duration of action, isn't it? Because 50% of neostigmine is excreted by kidney. It will have. What about glycopyrrolate? Is it also requires kidney for its excretion? 50% of glycopyrrolate is excreted through kidney. So it is also getting prolonged. So that way, no problem. Don't expect any neostigmine to produce problem, because this thing is also, glycopyrrolate is also there. So that way it looks after the antimuscarinic effect that is required whenever you give neostigmine. Okay. So what about post-op analgesia? What drugs you want to use?
We'll go for a multimodal analgesia, and we can give paracetamol for this patient. Then a dose of opioids can be given at a regular interval.
No, when I ask about post-op analgesia, you should always think about, so, you know, the local infiltration of the local anesthetic is also very important, isn't it? So you see, laparoscopic or TEP surgery, why we are taking up the patient is because it produces less pain in the post-operative period. The patient can have early mobilization. So those are the advantages, isn't it? So that is why, you know, just infiltration, or even you can go for tab block.
Yes.
Isn't it? So that also you can definitely use in the post-operative before extubating the patient, or definitely local infiltration at the site of the trocar that has been introduced with paracetamol. That is more than sufficient for these patients in the post-operative period. Can I use tramadol in the post-operative period?
No, sir. Tramadol should be used cautiously. It will produce an active metabolite or desmethyl tramadol, which is eliminated by the kidney, which has a lower seizure threshold. So it should be available.
Very good. So that is why you have to be careful in using tramadol. What about pethidine?
Pethidine also produces an active metabolite called norpethidine, which is also epileptogenic. It is also excreted by the kidney, so it should also be avoided.
So you have to be careful in what kind of post-op analgesia you are using. So these things are fentanyl. Definitely you can use if you think that the patient, other surgeries where you know, the patient has got probably more pain. So patient-controlled analgesia using PCA pump, using fentanyl also, or remifentanil, definitely you can use in the post-operative period. Okay, so suppose if this patient is posted for open inguinal hernia repair, what technique you would have used?
We'll opt for a combined spinal epidural for this patient.
Would you go for an epidural? You said that epidural can produce problems. The needle can go through and through, and epidural hematoma is very common because these patients have coagulopathy. And do you expect, prolonged duration of surgery where epidural is required, or post-op analgesia is required because too much of pain will be there for surgery? You don't expect, isn't it? It's a simple hernia repair. Any patient with simple hernia repair comes to you, what anesthesia would have given?
We'll prefer spinal anesthesia.
Isn't it? You would not have gone for combined spinal epidural. Isn't it? So that is one thing. And what kind of spinal anesthesia? You have gone for a selective spinal anesthesia. Selective spinal anesthesia, or even you can go for, field block, for inguinal field block. So just remember about these things also can be asked for you in the exam. Inguinal field block with now ultrasound guided inguinal field block is becoming very popular and becomes very easy also. And remember about how to give ultrasound guided inguinal field block. Let us not discuss about these things because of lack of time. So anyway, another question they may ask you is for renal transplant surgery. If this patient is posted for renal transplant, how are you going to manage this? Because you are doing renal transplant surgeries in your hospitals.
Yes.
Isn't it? So if a patient is with the CKD, suppose for one student they would have asked everything about non-renal surgery anesthesia, and another student they may want to ask about patient posted for renal transplant surgery. So that you also remember about. Okay, so you have to read about that also. So anyway, and one more scenario they may create is patient with already had a renal transplant. That patient may also come to you in the exam. They may post or they may keep the patient for your exam. So what problems you expect? Because these patients will have the immunosuppressive agents. These patients will be on corticosteroids. He'll have the other drugs, anti-metabolites. So multiple drugs to suppress the immunity will also be there. So their effect. So that also we'll have to think about. Okay. So let us conclude because we have taken almost nearly more than 1 hour. So thank you very much. So one thing I just want to tell you that you have really prepared very well and you've answered very well. And that is the reason, because you are answering well, we could discuss majority of the things. What the questions that usually can be discussed in the exam. So most of the questions we have discussed because it depends on how fast you can answer for that question. So nice answers. So remember that in the exam also, answer to the point, short answers.
Okay.
So that the examiner can ask more number of questions. You can answer more number of questions, get more marks. So all the best. So you have done extremely well. I would have given about 80 marks out of 100 for this case.
Thank you, sir.
Very good. Very good.
Thank you, sir.
I would like to thank again ISA Kerala for this opportunity as well. Right, Arjun? Thank you.
A very good evening to the eminent faculty, seniors, and dear postgraduates. Welcome to the 19th episode of ISACONNECT Faculty Quiz. We had an excellent academic session. Thank you, Gurdat sir, Dr. Emil, and Dr. Anita. As usual, our quiz is based on the previous episode of AnaesthesiaCONNECT webinar, the 18th episode. Please note our game pin is 5644558. I repeat, 5644558. Please access the quiz through the Kahoot app or Kahoot window. While you are attending the quiz, please focus on the Kahoot window and not on the YouTube. Please join the quiz by entering the first 4 letters of your name, followed by your 10-digit phone number. There are 5 questions. You'll get 30 seconds to answer each question. First 4 questions will carry 1 point each, and the last question carry double points. The winner will receive a cash prize of 1,000 rupees, and the first and second runner-up will receive a certificate of appreciation. So, shall we start the quiz today? Our game pin is 5644558. I repeat, the quiz pin is 5644558. So now we'll start the quiz. So I remind all the participants to check out the Kahoot window only during the quiz for seamless experience rather than looking at the YouTube. So please enter your name, the first 4 letters of your name followed by your 10-digit phone number. Again, I want to remind you about the golden question, the 5th question, the last question, which carries double points. So let us see the winners of the last week. The winner is Dr. Anjali Aravind from Anandapuri Hospitals and Research Institute, Trivandrum. Congratulations, Dr. Anjali. And now we'll see the first runner-up, Dr. Sunny Alex from KMCT Medical College, Kozhikode. Congratulations, sir. And the second runner-up, Dr. Virendra Pradap Maurya from Christian Institute of Health Sciences and Research, Nagaland. Congratulations, Dr. Virendra. So let's start today's Kahoot quiz. I hope everyone is ready to answer the questions. So we'll go to the first question. First question, liquefaction of gases is based on. First option, Poynting effect. Second option, Quanda effect. Third option, Laplace effect. And fourth option, Joule-Thomson effect. Literally, the effect is displayed on screen. You have 5 more seconds to answer. The answer is Joule-Thomson effect. 8 people have marked it correctly. When a gas at high pressure is allowed to expand under adiabatic conditions through a porous plug to a region of low pressure, there occurs a change in temperature. In liquefaction of air, the air is compressed to a pressure of 200 atm and then it is passed through a water-cooled pipe. Then it's allowed to pass to a low pressure area, which results in cooling of the air. Then the cycle repeats and the gas reaches its boiling point and then gets liquefied. This is the principle behind liquefaction of gases. We'll move on to the scoreboard. You can see the scoreboard is led by Alex, then Sruth, and followed by Priya. They have very close points. And we'll move on to the second question. Which of the following drug has poor oral bioavailability? Which of the following drug has poor oral bioavailability? First option, dabigatran. Second option, apixaban. Third option, clopidogrel. Fourth option, rivaroxaban. You have 5 more seconds to answer this question. The answer is dabigatran. 11 people have marked it correct. Dabigatran has poor oral bioavailability, which is around 7%. It is an oral competitive inhibitor of thrombin. Even though it has poor oral bioavailability, it is still given as an oral preparation. Other options, apixaban has an oral bioavailability of 50 to 85%, clopidogrel has 50%, and rivaroxaban has 80 to 100%. We'll move on to the scoreboard. Now the scoreboard is led by Priya, followed by Anju, then Mutta. Then we will move on to the third question. As per ASRA guidelines, high-dose apixaban should be withheld for how long before neuraxial anesthesia? Repeat, as per ASRA guidelines, high-dose apixaban should be withheld for how long before neuraxial anesthesia? First option is 36 hours, second option is 48 hours, third option 72 hours, and fourth option 5 days. The correct answer is 72 hours. High-dose apixaban is 5 mg BD or more. It should be withheld at least 72 hours before neuraxial anesthesia. Low dose is 2.5 mg OD or BD. It can be withheld 36 hours prior. And first postoperative dose of high-dose apixaban can only be given after 24 hours of removing the catheter or needle insertion. And if at all you are planning to give neuraxial anesthesia before 72 hours, we have to check the anti-10A plasma levels and ensure that it is within the normal limits. Then we will move on to the scoreboard. Priya is still leading the scoreboard, followed by Anju and Mutta. And 4 participants just hit answer streak 3. All the 3 questions are correct. Then we will move on to the next question, the 4th question. The most important variable determining the time constant for volatile anesthetics at the level of alveoli is? Option 1 is functional residual capacity. Option 2 is alveolar ventilation. Option 3 is alveolar blood flow. And option 4 is blood gas solubility. You have 5 more seconds to answer this question. The correct answer is alveolar ventilation. 14 people have answered it correctly. As we all know, the time constant is equal to the volume by flow. At the level of alveoli, it is FRC by alveolar ventilation. Alveoli is a site where the equilibration is very fast, but it cannot equilibrate more than what it received, which is the alveolar ventilation. I take this opportunity to also remind you the most important variables at the other sides. At the circuit level, it is fresh gas flow. At the blood level, it is blood gas solubility. And at the level of brain, it is cerebral blood flow. Then we'll see the scoreboard. So the scoreboard is led by Muthu, followed by Priya and Anju. Then we will move on to the last question, the golden question, which carries double points. So let's see the question. Please be ready to answer. To calculate DLO2 from DLCO, DLCO is multiplied by a factor of, option 1 is 1.32, option 2 is 1.23, option 3 is 2.23, option 4 is 2.32. So 10 people have answered it correctly. The answer is 1.23. The numbers were very close and confusing, but still 10 people managed to answer. This is because the diffusion coefficient of oxygen is 1.23 times the diffusion coefficient of carbon monoxide. We measure carbon monoxide instead of oxygen to assess the alveolar capillary membrane because the carbon monoxide has high affinity to hemoglobin, which is about 210 to 250 times. It can freely transfer and provide a sustained maximal pressure. So, and it is also limited by the integrity of alveolar capillary membrane rather than alveolar blood flow, unlike oxygen. Hence, it can provide a clearer picture about the alveolar capillary membrane when compared to oxygen. So we'll go to the scoreboard now and let's check who's the quiz winner. The podium is ready. The second runner-up is Shan and the first runner-up is Anju and the winner is Muthu. Congratulations to all the winners. Thank you all for participating in the quiz. Arjun.
Arjun, your mic is muted. Please unmute.
Sorry. Thank you, Dr. Nishana. I'll hand over the podium to Dr. Benil and Gurdat sir also is there for any.
Thank you, Dr. Arjun and Dr. Nishana. It was an excellent quiz time. And congratulations to the winners. And I hope Dr. Sanish is there or he is not there. I can't see him. Okay. I express my sincere thanks to Dr. Gurudat for the excellent show today. It was a wonderful presentation. He actually covered almost all the areas of chronic renal failure for anesthesia. We started almost at 7 o'clock and almost more than 1.5 hour or 1 hour 45 minutes. It was a very wonderful session by Gurudat sir. And especially Dr. Emil and Dr. Anaka, they've done the show very well. They have answered the questions in an excellent manner. So congratulations to Dr. Emil and Anaka. And I also would like to extend my sincere thanks to their HOD, Lata Madam. Actually, due to some personal reasons, actually her mother expired yesterday. So she couldn't join us today because of that particular reason. So I express my sincere thanks to Madam and the department for preparing them for today's session. And anything else to add, Gurudat sir, please So I'm happy to see that sir is still answering the questions in the chat box.
No, I tried to answer, and most of the questions, I think, whatever the doubts the students had, I tried to answer. I think they should be satisfied.
Thank you, sir. Thank you very much. And shall I wind up the session, sir?
Yeah, it's because Sanish had told me that time is not a problem.
Yeah,
But
time is not a
still,
problem. The thing is that we have to cover all the areas of that particular chapter. That's all.
Yeah,
Because
correct.
this should be useful for the students, those who are preparing
Yeah.
for the examinations.
That is
So
what
once again,
ISA Kerala Connect is mainly for the students.
yes,
So
sir.
students should be benefited. So time should not be a factor like another set 15-20 minutes that side, this side. So
No,
thanks
that is not an issue. Actually,
for, yeah,
the important part is that we should cover almost all the questions,
correct.
and it should be useful for all the students those who are watching the show.
Thank you.
And I would also like to extend my sincere wishes to all the wonderful women in our specialty. And as we are closing, tomorrow is the World International Women's Day. So my wishes to all the women in our special fraternity. And thank you. Good night.
Thank you.